Kia ora, and nau mai haere mai to tonight's webinar. Tonight we're doing a webinar on meningitis and the Bexsero vaccine. The webinar tonight is supported by GSK. My name is Katie McCulloch. I'm a nurse practitioner who works in primary healthcare and for the Goodfellow unit. Tonight's topic is focused on meningitis. We will provide an overview of the newest meningococcal vaccine, Bexsero, which is broadly protective against meningococcal group B disease and is different to the MenZB vaccine that was used in New Zealand between 2004 and 2011. Our speakers include Dr. Cameron Burton, an Auckland-based paediatrician undertaking a PhD on invasive bacterial disease in children, Dr. Emma Best, an Auckland-based paediatric infectious diseases specialist and senior lecturer at the Department of Paediatrics, Child and Youth Health, and medical advisor at the Immunisation Advisory Centre at the University of Auckland, and Bernadette Heaphy, a registered nurse and program manager at IMAC. Over to you, Cameron.
Tēnā koutou katoa. Ko maunga kia te maunga, ko haura ki te awa, no tamaki makaurua hau, ko Burton tōku whānau, ko Cameron tōku ingoa. Kia ora, my name's Cameron Burton. I'm an Auckland-based paediatrician and I'm currently working on my doctorate in bacterial diseases in kids, one of them including meningococcal disease, and have been working part-time at Kids First Children's Hospital in South Auckland. So just thanks to Mary Nolan and Emma Best for helping with some of the preparation and slides around this talk. But we'll be talking tonight about meningococcal disease and the 4C MenB or the MenB vaccine that's just come out this month. So just an overview, talk a little bit about the clinical aspects of invasive meningococcal disease. Update you on the epidemiology, both internationally and in Aotearoa New Zealand, and then a little bit on the meningococcal vaccines and MenB vaccine itself, and then some of the practical aspects around that, such as the use of paracetamol and common events following the vaccination. I'm really excited because for the first time ever, in New Zealand, Aotearoa, control of meningococcal disease is within our reach. This is my first slide and I'm going to end on it as well. Just a little bit about the pathogen. So invasive meningococcal disease is caused by the gram-negative Diplococcus Neisseria meningitidis. This bacteria is categorized into serogroups based on its polysaccharide capsule, with 6 serogroups causing the majority of disease worldwide. And that's A, B, C, W, X, and Y, with B being the biggest disease-causing agent within Aotearoa. The bacteria is transmitted through respiratory droplets or direct contact with secretions. And humans are the only species that this pathogen can affect and colonize, which is really important because it means we've got a good shot of working towards elimination. Carriage varies across the lifetime, with the majority of carriage occurring in adolescents and young adults, about 20 to 50%. And less so in infancy and also in adulthood, but in certain situations such as outbreaks and close living situations, carriage can be in excess of 50%. The majority of cases occur in Aotearoa and worldwide in children under 5 years, and especially infants under 1 year old, with a second smaller peak in adolescents and an increasing risk in the elderly. Tamariki Māori and Pasifika children are inequitably affected by this preventable condition. Following an incubation period of 2 to 10 days, but commonly 3 to 4 days, the meningococcus invades the respiratory epithelium and enters the bloodstream, where it replicates rapidly to high copy numbers. Fulminant infection is often preceded by a prodromal stage, which may include non-specific symptoms such as fever, coryza, sore throat, myalgia, or vomiting. The major manifestations of meningococcal disease are meningitis and severe sepsis, with the hallmark petechio-purpuric rash indicating meningococcal bacteremia. Early treatment, or early recognition and then treatment of IMD is critical, as sepsis can progress rapidly to multi-organ dysfunction and death. Admission to intensive care is required in around a third of cases. Case fatality rates are high, even with appropriate treatment, of around 4 to 15%, depending on the setting and age. And around 1/3 of survivors are left with long-lasting complications, such as hearing loss, neurodevelopmental impairment, loss of digits or limbs, skin scarring, and also it imposes a significant psychological impact on survivors as well as their whānau. This is the two major manifestations of meningococcal disease. This data comes from a study we did in the Auckland region in children under 15 years between 2004 and 2020, where we had 319 cases and 318 children. So you can see from the Venn diagram in the middle, quite a bit of an overlap between bacteremia with that purpuric rash on the right, and then meningitis with a smaller subset, septic arthritis. And about a third or 40% of the cases having both meningitis and bacteremia. Internationally, the global incidence of meningococcal disease has been largely declining over the past 20 years, in part due to successful conjugate vaccination programs. And in the majority of developed countries, incidence is less than 1 per 100,000 population. The MenAfriVac meningococcal A conjugate vaccine has led to the virtual elimination of Group A meningococcal disease in Africa's meningitis belt, with 60% reduction in epidemic meningitis, all-cause meningitis. However, we are seeing serogroup replacement in that region, especially from MenW. And from 2009, there has been a worldwide increase in serogroup W, driven by this hypervirulent ST11 clonal complex. That's a story elsewhere, but Aotearoa still reports the highest rates of Group B meningococcal disease in the world, as well as the highest rates of all meningococcal serogroups outside the meningitis belt, which are sitting well over double most developed countries. A bit about our history. Many of you may remember New Zealand experienced a prolonged epidemic of Group B meningococcal disease, beginning in 1991 and peaking in 2001. Incidence spiked at 17.4 per 100,000, with an attack rate as high as 212 per 100,000 in infants. That's 1 in every 500 babies. The epidemic was driven by a particular strain of serogroup B, P1.724, which is characterized by its outer membrane protein, POR-A. In response to this, a tailor-made out-of-membrane vesicle vaccine, MenZB, was developed, directed against the POR-A. MenZB was administered between 2004 and 2006 for all children less than 20 years of age, and for infants on the New Zealand immunisation schedule between 2006 and 2008. And in all, more than 1 million young New Zealanders received this vaccine, including myself, with coverage of up to 81% and effectiveness of around 75%. Although the epidemic was naturally waning, the truncation of the epidemic due to the vaccine is estimated to have prevented up to 6 deaths and 30 cases of severe sequelae. However, since 2014, rates of invasive meningococcal disease have been steadily increasing through to 2019, where peaks were just as high as the tail end of the epidemic. In Northland, we saw regional outbreaks of Group C in 2011 and Group W in 2018, which were associated with high case fatality rates and prompting emergency vaccination programs. But since 20, there has been a sharp decline in meningococcal disease during the COVID pandemic, which is largely driven by lockdown measures and a reduction in circulating respiratory viruses. So we've had about 2 years of respite. This on the left graph shows some data from ESR before opening up again and then seeing a gradual increase or a moderate increase over 2022, approaching the pre-pandemic levels. This year, or last year, 2022, there's been 69 cases, including 3 deaths, 2 deaths in children under 5 and 1 in a young person aged 15 to 19 years. Half of this last year's cases are in children less than 5 years, with the majority of these cases affecting children Māori and Pacific ethnicity. Currently about 80% of our meningococcal disease is still Group B, with Group Y and W making up the remainder. Look, this is a little bit more on the Auckland data in children between 2004 and 2020, looking at who, at least in young people, are affected. The median age we saw was 18 months, with large numbers of cases occurring in children less than 1 year. Māori and Pacific peoples were at a significantly increased risk compared to non-Māori, non-Pacific peoples, with Māori having a 6 times more higher risk of meningococcal disease, and Pacifica children 7 times. About 60% of all cases occurred in quintile 5, which is the 20% of the population which has the most socioeconomic deprivation. And in those 319 cases, there were 13 deaths, which was a 4.1% case fatality rate. That's comparable to the lower end of developed countries internationally. And there was sequelae in just under a quarter of children and young people. Vaccination remains the best strategy to eliminate meningococcal disease. With the ACWY-X vaccine now in clinical trials, there are safe and effective vaccines available for all major disease-causing meningococcal serotypes. Polysaccharide protein conjugate meningococcal vaccines have been available for the past 40 years and induce lifelong lasting immunity. These are the current non-B vaccines available in New Zealand: Menactra, which will soon be replaced by MenQuadFi, and Numeric's ACWY vaccines, with NiceVac-C being a Group C vaccine. Menactra and MenQuadFi are funded for those aged 13 to 25 living in boarding schools, halls of residence, military barracks and prisons, as well as individuals with certain high-risk medical conditions and close contacts in cases of meningococcal disease. But development of vaccine against serogroup B has been more complicated, as the polysaccharide capsule is poorly immunogenic. This is due to its similarity to human fetal neuronal cells. Bexsero was licensed in 2013 and contains 3 recombinant proteins, including the New Zealand MenZB pore A outer membrane vesicle. So our MenZB meningococcal vaccine heritage has been reused and lives on in the Bexsero vaccine. This vaccine was first approved for use in New Zealand in infants over 8 weeks in 2018, and in July 2021 was funded for high-risk groups. At least 12 countries now include MenB vaccine in their national immunisation programs. Real-world data from Australia, Canada, Italy and the United Kingdom show reductions of 71 to 100% in MenB invasive disease in eligible cohorts 2 to 5 years following the introduction of this vaccine. Aside from reduction in MenB serogroups, there's also emerging evidence that outer membrane vesicle vaccines provide some protection against meningococcal disease caused by non-B serogroups, as well as Neisseria gonorrhea. Unfortunately, though, it does not appear that Bexsero affects meningococcal carriage, which means we're reliant on direct protection for meningococcal B. So this requires adequate circulating antibody levels following direct immunisation, which are expected to wane over a several-year time period. So this is why we're giving it in infancy and in adolescence, because these are the times of highest risk that we want to target to have adequate antibodies. There's a detailed Bexsero evidence review can be found on the IMAC website. As infants have by far the highest rates of meningococcal disease, it's important that immunisation occurs early. In our Auckland cohort, we looked at meningococcal disease in 118 infants under 1 year old. The left figure shows the age in months at presentation of meningococcal disease. The peak age was 3 months and median 5 months. The dark blue proportion indicates meningococcal disease caused by serogroup B, which is still the majority and the one that is potentially protective by MenB vaccine. The right two figures show ages of the cases who died and cases who had serious sequelae. So these most commonly occur in infants who present or who contract the infection aged 3 to 4 months. Given the increased risk to Māori and Pacifica infants, it's especially important to prioritise early vaccination for them. MenB is a safe vaccine. However, it's also a reactogenic vaccine. Most infants and young children will experience at least one reaction, which may include injection site tenderness, mild to moderate fever, unusual crying, malaise or irritability. See from this table that Bexsero alone is only slightly increased reactogenicity compared to routine vaccines, but it appears when this vaccine is used in combination, there's an increase in fever and injection site pain. And so around 50 to 60% of infants will develop a fever when given with other routine immunisations. This fever usually peaks about 6 hours and subsides within 24 to 48 hours. There's been, for subsequent doses, there's been no increase in intensity found. MenB has been used in the routine immunisation schedule in England since 2015. Safety review of 3 million doses given found no significant safety concerns and no increase in febrile seizures. Prophylactic paracetamol has been found to significantly reduce both the occurrence of fever as well as the height of fever and other local systemic reactions. Although immunisation-induced fever is a concern as it can result in unnecessary presentations to healthcare, including invasive investigations and intravenous antibiotics. There's been a small but significant increase in fever-related consults in the UK following the introduction of MenB. However, vaccination to avoid adverse events puts infants at unnecessary risk of meningococcal disease, as well as other vaccine-preventable diseases. For this reason, in looking at paracetamol and immunogenicity, there had been some previous studies which demonstrated lower antibody titers following paracetamol for pneumococcal and Haemophilus vaccines. But no impact on carriage or invasive or clinical infections has been demonstrated with paracetamol. In studies looking specifically at MenB vaccine, it has been shown to be no reduction in antibodies following paracetamol, and as well, MenB does not appear to reduce the immune response to other vaccines when given concurrently. For these reasons, and on balance, we're recommending prophylactic paracetamol in under 2s when receiving MenB. This is to avoid fever and discomfort for the infant, as well as reducing the risk of unnecessary healthcare presentations. We're advocating for 3 doses, one given just before or just after vaccination, and then 2 further doses around 6 hours afterwards. For the first time ever, control of meningococcal disease in Aotearoa is within our reach. Thank you.
Lovely, thank you, Cam. We're just going to move on to Bernadette now.
Kia ora koutou, everyone. Ko Bernadette Heaphy tākuingoa. I'm the Program Manager over at the Immunisation Advisory Centre. I'm based down in Wellington, and it's great to be able to talk to you this evening regarding the MenB program. And I will also just touch on alongside the ACY&W program for our adolescents. So I think I'd like to start with supporting what Cameron has said around how exciting this opportunity is, the opportunity to be able to protect infants and our young people in close living conditions against meningococcal B. So things you possibly already know, the Bexsero vaccine, the MenB vaccine is available to be ordered from ProPharma. If you had existing stocks in your fridge that you may have ordered for high risk vaccination groups, please just check any expiry dates before you use that vaccine. They do come in single box doses, so that's not great in terms of taking up space in the fridge, so you do just need to be a little careful around making sure that you order it regularly, remembering there's the 2 free deliveries each month from ProPharma. It's manufactured by GSK, and it's actually manufactured in Italy, which is a bit of a change from the usual GSK vaccines, which are manufactured in Belgium. Comes as a pre-filled syringe with a lower lock, and there's no needle supplied, so you will need to make sure that you've got your supply of needles, and making sure that you've got a range of needles appropriate for the age groups of patients and the size of patients that you'll be vaccinating, remembering that it is really important to get this vaccine into the muscle, so it may be needed that you use a longer needle, especially for some of our bigger patients. It's 0.5 of a ml for IM administration. So where does it sit on the schedule? On the routine schedule, it is currently sitting in at 3 months, 5 months and 12 months. However, there is an approved alternate schedule, which if you look at CAM's data, it's really important to think about offering this opportunity to our tamariki, that they do get offered the opportunity to have the vaccine at 2 months, 4 months, and then their 3rd dose, their booster at 12 months, just to try and get ahead of that, peak at around 3 months. While with all use of medicines outside their licensure, it can't be promoted, it is possible if parents request to provide Bexsero on prescription at 6 weeks. But it's also really important, if we are providing Bexsero vaccine at 2 months, 4 months, that we don't delay the 6-week immunisations. It's really important that we continue to make sure that vaccines are offered on time for the best protection. Some resources are now available, and so I've just taken a bit of a screenshot there of some of the resources from Health Ed, which health providers will be used to seeing. So the schedule card has been updated and Bexsero added to it, along with the after your child is immunised tear-off sheet. Now, they're not currently available for you just to order and get the tear-off pads sent to you, but they will be coming shortly. So for now, it is possible to print them off. We've also got a range of resources on the IMAC website, and we've got from our front page of our website, you can go straight to our MenB resource page, and with a few frequently asked questions and information available there. Just to note that some of the patient-facing information, so like the handouts for adolescents around the meningococcal program, they're available through Health Navigator, as well as the Dropbox, which the National Immunisation Program team provide. So, Bexsero MenB, it's a new addition to our schedule, and as with all new additions to the schedule, we generally offer it in a limb of its own. So while it's not a new vaccine, it has been used internationally since around 2012, and it has been used in New Zealand for since 2018 and on the schedule for special groups since July 21. But because we're putting it into the routine schedule, just for now, just to keep an eye on any site responses or post-vaccine responses, we're recommending it goes into a limb of its own. Now, for children at the age of 12 months where they're due their booster dose, and for some kids for now, they'll be playing catch up, and so they'll be having their first doses. We need to judge the site that we're going to use based on the development of the deltoid, the size of the child, as to whether or not we're going to use the deltoid or the vastus lateralis for providing that IM injection. As always, the handbook provides a range of information and guidance around vaccination choice, and you'll see for there that from 12 months to 3 years, you do have a choice between the deltoid or the vastus lateralis. If the deltoid is sufficient and big enough, then it's a great sized site to use in this age group, particularly around those kids who are now active and mobile, and we're not wanting to interfere with that process. Just to note, the handbook is being updated, and it is always really important to go to the online version of the handbook, not a hard copy. Unfortunately, they are now very out of date, and I think we're on something like the 21st edition of updating the 2020 handbook. So there is a catch-up program. So alongside adding it into the routine program for the infants, there's a catch-up program for kids who are aged under 5 years. The eligibility criteria from PharMac allows for, if a child has their first, sorry, I'm just moving stuff around so I can see my notes. So if a child receives their first dose, 2 doses under the age of 12 months, they can have their 3rd dose even if their 12-month visit is delayed. So they may be a little bit older than 12 months when completing their course. For children who have started using private purchase vaccine, if they are under the age of 5, then they can continue with their course and complete using funded doses. If a child, so we will have had a few, we're 1 week into March, so some of those kids will have had their first dose of Bexsero vaccine and will now turn 5 years. If they've had their first funded dose under the age of 5 years, then they're also allowed their 2nd dose over the age of 5 years. But kids who were already 5 on the 1st of March aren't eligible for this catch-up program. So what I've included here is a copy of the table that we have put together in the immunisation handbook around the doses that are required for the kids starting at different ages for the catch-up program. I really did also want to touch on and not let us forget about vaccinating our rangatahi. It's really important to offer them the MenB protection for those who are living in close living circumstances. So that's things like boarding school hostels, tertiary education halls of residence, military barracks or prisons. There are a number of posters and flyers available in the Dropbox that the National Immunisation Programme have available. And they cover the whole range of meningococcal vaccines. So for this age group, for those who are in their first year of living in those close living circumstances, they are eligible for their MEN, AC, Y and W, as well as their MenB. For those who have been living in those close living circumstances for longer, they will be eligible for the catch-up for the MenB program. So for this age group, the MenB vaccine is 2 doses, 8 weeks apart. Also, don't forget to offer them influenza at the same time once it becomes available. Just wanted to add a note in here around the differences between Menactra and MenQuadV, because we're going to have both of these vaccines around for a while. So these are the Men AC, Y and W vaccines, and we'll be mostly familiar with the Menactra vaccine. And a few questions have come up around the differences between the two. I refer you particularly to the handbook to look at the dosing for how many doses are required and what age groups it can be used in. But it is a pretty similar vaccine. And as you can see, the post-vaccination responses are pretty much the same across the board. Okay, so giving MenB to our under 2s. Cameron's already done a great job of just taking us through the use of paracetamol and that its recommendations around timing for being given with Bexsero vaccine. And just, so just add this in here that we don't routinely recommend it around all immunisation events. It is specifically for the under 2s and specifically related to the giving of the MenB vaccine. It is still really important that parents get clear information around cooling cares and knowing how to treat or deal with fever in the first instances. Also just noting that for infants who are enrolled in the PIPA study, they will use whichever paracetamol or ibuprofen, depending on which arm of the study they are in. And they will have information around what to give as part of that study advice. So in general, the regime around giving prophylactic paracetamol is that we're going to give a dose either at the time of vaccination or up to 30 minutes prior. We give a second dose 4 to 6 hours after the first dose and a third dose 4 to 6 hours later. So if a child is sleeping when they're due their second or third dose, then it's not necessary to wake the child up. And the dose can be given when the child wakes up, provided it is at least 4 to 6 hours after their previous dose. So it's really important that we're clear around giving this advice and information to parents when they've brought their child in for vaccination. Now, some of you will have noticed that we're giving 3 injections to these littlies, and it's like, where do we put them all? So just a reminder around finding the injection site on the vastus lateralis and finding your upper marker, so the greater trochanter, and finding your lower marker, the lateral femdole condyle. And then dividing that area into thirds, and your injection site is at the junction of the upper and middle third. If you've got to put more than one injection into that little leg, What we're looking at is that you do the same process, dividing your site up. Your first injection site, so at that junction of the middle and upper third is your first injection, and then slightly above that, about 2 centimetres, is your second injection site. And so, as I said before, when we're giving the MenB vaccine, as a general recommendation, it goes into a limb on its own. So at the 5-month event, you're looking at giving the Infanrix Hexa and the PCV13 into one vastus lateralis, and then the MenB into the other. So landmarking for the deltoid injection site, this applies the same for our rangatahi as it does for our tamariki in terms of looking for your injection site markers. So looking for the acromion process, so that knobbly bit at the top of the shoulder, the deltoid tuberosity where the deltoid thins down and attaches into the humerus, and then your injection site is halfway between the two. Now for some people that's in line with the axilla. So you may find that by taking a line across, it is halfway between those two markers, but it's really important to find the two markers and then find that halfway point. And you're giving the vaccine into the bulkiest part of the muscle. Just refer back now to the discussion before around if at 12 months they have insufficient deltoid bulk, then yes, you'll be looking at doing 2 injections into one vastus lateralis. But certainly the deltoid in some of our 12-monthers onwards is sufficiently formed for being able to give those intramuscular injections. So we've done up a new 3 in a row poster. Now these are just guidelines around a suggested framework for using for how do I give my injections and in what order, but they are recommendations rather than requirements. So in general, we've suggested that you do the MMR vaccine first, and that's because it does remain a priority in making sure that we are getting our young people covered for measles. So doing the MMR into the first vastus, your MenB into the deltoid, and then your PCV13 into the other vastus lateralis. I can almost hear you saying it. What happens at 15 months when I know I'm going to be offering this kid a MenB vaccine? How do I make this all fit? Suddenly it's going to be 4 in a row. We've done it before. It isn't the first time. And the order in which you do it, this is just a little play with the poster from before, and based on the current recommendations around how we do the 15-month immunisations. But doing Hib in one vastus lateralis, the chickenpox in the deltoid, MMR in the other vastus, and then using the deltoid for giving the MenB if you're doing a catch-up. Now, if you've got questions around vaccine administration, where do I do it? How many injections can I possibly give? And, don't hesitate to contact IMAC on the 0800 clinical advice line or send us an email. Now, pain, it's always hot on everyone's mind, and not just parents, but us as health care professionals. We also want to minimise pain for the people that we're working with. So there's the general steps that we always encourage. So avoiding syringe aspirations, so no need to pull back on that plunger. It only prolongs the time that the needle is in the muscle. Encouraging breastfeeding. It's really important, and it really does help, distract both mum and babe, and just having that opportunity for that connection. Administering the vaccines and in order of increasing pain. Now, we used to say that MMR vaccine was really stingy and it was uncomfortable. But that does seem to have changed a bit with the move to it being given IM. So it doesn't seem to be as sore. And certainly that's the anecdotal discussions with adolescents who are receiving MMR or Bexsero, that the Bexsero is just that bit more stingy. But it's also, we do need to make sure that we're getting vaccines in as priority. Particularly with our young people, just making sure around how we talk, keeping experiences calm. I remember during the MeNZB campaign and those 4-year-olds who did not want to come back and see us again as primary healthcare nurses, and they knew what was going to be happening and how important it was for us to just try and stay calm, keep the parents calm, and just keep working with those children. And I think particularly for our young people, avoid being excessively reassuring, because they know it's going to be sore, they know it's going to be uncomfortable, and the more, in some ways, the matter of fact we can be about it, the easier it is for them to get through. Also avoiding anxiety promoting terms, so things like shot, which aren't particularly correct, and they do promote some level of anxiety, so keeping it neutral with the clinical terms. For our young ones, giving them the rotavirus vaccine first, that high sucrose, really helpful at that 6-week and 3-month event. Young children, sitting them upright, being held comfortably, not being excessively restrained, and explaining to them. And I'm a big believer in bribery and corruption when it comes to our young tamariki. There's nothing like the promise of something good to happen afterwards, whether it's like with the 4-year-old events, getting a new school bag, or something that they're able to go, yes, I've got that to look forward to. It might be their favourite dinner cooked at home. It might be a little bit of extra screen time. It doesn't have to be something big. Coaching children, adolescents, and sometimes parents through abdominal breathing can be really helpful, and using distraction on all age groups. It doesn't just apply to children, whether it's a toy, a book, screensaver on the computer, bubbles, counting backwards, having a chat about something that interests the person who's being vaccinated. Post-vaccination advice. So as I've already mentioned and as Cameron mentioned before, it is going to be really important that we give good, clear advice around the use of paracetamol. What are the expected responses? What to do if they're concerned or worried, who to make contact with, what they can do to self-manage, and when it's appropriate to seek healthcare. Making sure that we're giving both written and verbal information, and that includes phone numbers for being able to contact and discuss, whether that's Healthline or an after-hours service that you run yourselves.
Wonderful. Thank you so much for that, Bernadette, and thank you, Cameron. We do have a few questions coming up. So we've got Emma, who's also going to be joining us for the panel for questions. So let's get started. So will IMAC be releasing whānau-friendly info regarding paracetamol and the side effects to aid vaccinators, and to reassure the whānau about the need for paracetamol?
I'm hopeful that Bernadette will also answer this, but yes, there's some information already on our website. Someone asked about the great 3 in a row poster that's available. You can just put in 3 in a row and you'll find it on the IMAC website. So lots of those resources that Bernadette's flashed up. I have to say that some of our stuff is specifically for healthcare professionals, and we also have a standing order available for those outreach immunisation services for paracetamol, so that some as in a pro forma you can use if you do want to work out how you're going to give paracetamol to perhaps outreach type immunisation services or other ones, so that 3 doses can be given. I definitely want Bernadette to type in here as well, but yes, there are some great resources.
Okay, sure. We've had advice as Emma's mentioned, we target our information at health professionals. So for you to take and to then put in a way which works for you and your populations. The public-facing resources come from Te Whatuora, from the National Immunisation Programme team, and they are working on those. And as I said, the tear-off sheet for handing out to parents, family, post-vaccination will be available very shortly to be ordered from Health Ed. But if you've got, I'm always happy, we're always keen to get feedback if there's anything in terms of what can we be providing for you to help you work with your resources specifically for your population. We'll certainly do our best. Yeah, and I don't think our standing order template's up just yet, Emma, but I'll be back at work on Friday, so I might be doing some harassing about that then.
Yeah.
Wonderful. That sort of segues into just a bit more of a reiteration around the paracetamol doses and when they're due. So someone's just asked, if it's nighttime when the second paracetamol dose is due, would you recommend waking the child up overnight at all?
So we don't recommend waking up overnight to give the paracetamol. But yes, other than that we will be suggesting definitely giving it 30 minutes before at the time of immunisation, 6 hours later, or 4 to 6 hours later, and a third dose another 6 hours from that. So we don't recommend, that's correct, isn't it, Bernadette? We don't say wake up infants.
Yeah, that's correct. Yeah.
Never want to wake up a sleeping infant. Definitely.
No.
So if they've had the BCG and therefore the left deltoid has been used, should we be giving the Varivax and the Vastus lateralis at 15-month IMS?
Certainly, if you're running out of choice of injection site. So with the BCG vaccine, you can't give anything else in that left, had to think about which side it was, into that left deltoid area for at least 3 months afterwards. So yes, you'd be potentially looking at doubling up into a Vastus lateralis. If we can try and keep the MenB vaccine on its own, then that's helpful as well.
Okay. And just a quick question, when you showed the slide, Cameron, about the different vaccines and when you can give them solo or give them with the routine vaccinations, you do have a higher instance of side effects. Would people be inclined to maybe spread them out, or would you not recommend spreading out your routine and the Bexsero?
So we've got 2 options in the schedule, or 3. 2 official ones, that it's been listed in the 3-month and 5-month immunisation event. But you also have an option of offering your whānau to have just the MenB vaccine at 2 months and 4 months. And that's 8 months or 8 weeks, 2 months is where it's first licensed for. So that's the earliest we can get it in. And I would be advocating especially for Māori and Pacific infants, because we still see meningococcal disease in that 3 to 4 to 5 month period. And ideally, as soon as you can get the 2 doses in, the better you'll be protected.
Yeah.
There's the additional prescription off license at 6 weeks. But just to clarify, if you are having the meningococcal MenB vaccine at 2 months and 4 months, that's a separate event, and you still need to have your routine ones at 6 weeks, 3 months, 5 months.
Yeah.
So it's the only vaccine you would give at 2 at 4 months. And that may reduce risk of febrile reactions.
Okay, lovely, thank you. And on the schedule at 5 months, it says next to Bexsero that it can be given at 4 months. Is this just all 5-month IMS or just the Bexsero?
Did I answer that?
Just the way it's pasted, is it, Cam, do you think? Because it's definitely only specific to Bexsero. It's just we're not advocating, we're not changing anything else about the timeliness of our infant schedule. If your infants are arriving at 6 weeks, they get their 6-week absolutely on time, get their 3 months absolutely on time, 5 months on time. That's still critically important. It's just there is an alternate option to try and get Bexsero in a bit earlier, that is giving it at 8 weeks, 2 months, as a separate visit and at 4 months as a separate visit, so that protection for vulnerable, more at risk whānau can be offered and enabled. It's a difficult thing to fit it into the schedule, and this is the alternate schedule has been one of the ways that's been attempted to get around.
Lovely, thank you for clarifying that. I think it is one of those things that's just trying to juggle, isn't it? So there's a bit of a few questions just about ordering resources. So someone tried to order some Bexsero from ProFarmer yesterday, and apparently it's not currently available. Do you guys know about the stocks at the moment in the country, or?
No, I do know there's been some delays earlier in the late last week for the sort of Hamilton area with deliveries from ProFarmer, but I haven't heard that anyone's out of MenB vaccine. However, in saying that, sometimes ProFarmer do have to redistribute stock depending on high order delivery in particular areas, but there certainly shouldn't be an ongoing delay in being able to order the vaccine. Normally when you'd go onto the ordering website, it would say if there's a particular vaccine that's out of stock and when it's likely to be back in stock. But I can certainly ask the clinical comms team to keep an eye on that for tomorrow. Yep.
Okay, thank you. Thanks, Bernadette, appreciate that. Just in terms of giving the Bexsero at 6 weeks, is the prescription for high-risk children only, and is there a specific criteria?
That's a great question. So no, I would say that you can enable the prescription for any infants concurrently with the 6-week vaccine if you're able to give the script. You can imagine that it's not always feasible for infants to be attending services and getting a prescription for additional vaccine, so we can't say that they pay for everybody, but of course I would like our most at-risk infants to get it at 6 weeks, but it's acceptable for any infant at 6 weeks with prescription, with routine vaccinations, the same issues around giving routine prophylactic paracetamol at that same time. So there's no criteria, but it does need a script because it is considered off licensing. It's been licensed from 8 weeks because that's how it's been used internationally.
Okay, awesome.
And Emma, just to clarify, if you are doing prescription 6 weeks off license, that's still funded and free to the family.
Absolutely. So yeah, can be enabled. And then the next dose can be given at 3 months, so at least 6 weeks plus following. And that would also need a prescription because it's not on the schedule at 3 months, but you can do that with the next routine immunisation.
Okay, awesome. Thank you for clarifying that for us. And this question's popped up a few times, just really wanting some clarification around if a 4-year-old has had 2 primary doses, which were paid for, can they have a booster dose?
So yeah, that's a good question. So that is a fully immunised child against meningococcal disease or with Bexsero if they've had 2 doses given prior to 24 months. They don't need a booster. If you've had 2 doses over the age of 2 years of age, you are well protected through to 5 years plus. You don't need a booster. The booster program is specifically for infants and those up to the age of 23 months, where we give 2 doses 8 weeks apart, plus a booster at 12 months or within the next 2nd year. So it's a different schedule based on age, and 2 doses given to a 2-year-old, 3-year-old is their protection right through to the age of 5. They don't need a booster dose. And yes, the paracetamol given at 6 weeks is acceptable. We've got our standing order will also have information around how it can be given down to the age of 1 month with correct gestational age as well. So there's even for premature infants some information you'll look on the New Zealand formulary and see that we can give paracetamol routinely from the age of 1 month in infants as well, without concerns, and we'll certainly do that at much younger ages as well.
Okay, thanks for that, Emma. For the MenZB vaccines for adolescents, it says that students in close living situations are funded. Does that include flatting situations for university students?
So I did respond to this one as well, but unfortunately at the moment it's actually specifically around communal living situations like hostels, where there's, you know, kind of an enrolment process, you're in a hostel or a university boarding accommodation or any other tertiary. I agree that a person who's living in a communal flat at that age group is certainly considered at increased risk of meningococcal disease, and it should be offered, but it's not actually incorporated in funding. You know, Cam responded to something else earlier, but we're certainly trying to redress that all of our young people at a certain time in their life are at increased risk due to different types of mixing, and that hopefully we can have this as a funded vaccine at the right, you know, appropriately in that age group, across age group, rather than based on their living circumstances. But offer it to your students who are going to communal flatting, unfortunately not funded in the same way.
Yeah, it's a bit of a shame, that, isn't it? And similar to that question, just those who are fully vaccinated when they're young, will they require a further booster when they're a teenager?
So we've had purchase available Bexsero probably since around 2018 in New Zealand. So we do have some young people who may have got this as a 13, 14-year-old. If they are more than 5 years since completion of 2 doses, 8 weeks apart, entering into student new circumstances like living arrangements that are communal, hostel, if it's funded, that's great. They get an additional booster funded. That'll be called their dose. And if it's not, I'd still be offering it. So again, I'm an advocate for young people living in situations where they're with other young people. That's a time they'll carry the organism again. As far as you know, at this stage, we think may need further doses at the 5-year moment if you're living in you know, accommodation where we would consider it more at risk.
Okay, thanks for that, Emma. Would you recommend 1 dose or 2 doses of the MenB vaccine for a 17-year-old who's in their first year of halls and only 1 paid vaccine at the age of 13 years old? Very specific case. But...
So they should just finish their primary course and have their 2nd dose now, and then they've had their 2 doses. That 2nd dose will give them a reasonable antibody response, and they've actually completed a primary course. They don't need an additional booster on top of that. You know, unfortunately, I can understand people might not get back to the 2nd dose, but having your 2 doses over the age of 2 years of age is your primary course, and that should be sufficient for that 17-year-old who's missed their 2nd dose.
Wonderful. Someone just wanted clarification on how long the protection lasts post-vaccination.
I think do you want to answer that, Cam? They're a little bit unknown. We are saying at 5 years at this stage.
At least 5 years, but I think we're still learning, you know, the longer the vaccine's been. Yeah.
And I think we do remember we're very specific about the age groups of highest risk. This is a rare disease, very severe. We want to protect everything, but actually under 5, particularly under 1s, and that time in adolescence are the 2 times through life when you're at most risk, and that's how we have to put the vaccine program over to protect those times of age.
Yeah. With pre-treating patients with paracetamol to prevent fevers, if the fevers themselves do not cause issues to the baby, is this really necessary, or are we primarily doing this to reduce parental concern?
That's also an excellent question. We might all be able to have an answer to this one. There's actually quite a bit of information that not only parental concern, obviously, but also medical concern. Infants that present to medical care, they might have unnecessary investigations, which might include urinary sampling, lumbar punctures, blood tests, to you know, ED visits, hospitalisation when they have a fever within the 24 or 48 hours following paracetamol. So it's also healthcare seeking behaviour that can be minimised by use of paracetamol. It does reduce potentially the risk of febrile seizure as well, although it doesn't always happen, but there is data from the UK showing that. It's not just about parental concern. This is quite a reactogenic vaccine. You know, 6 out of 10 infants will get a fever, and they will then, as they should, appropriately may seek healthcare. We can minimise that by using prophylactic paracetamol, and the data around Bexsero has shown it hasn't changed its immunogenicity and hasn't impacted on concurrent vaccinations immunogenicity by giving the paracetamol. So I think it's bigger than just parental concern. I think it's about subsequent impact of a program on healthcare behaviour, infants having appropriate investigations, getting additional antibiotics that may not be indicated because they're having an expected moderate adverse event post-vaccination. I hope that answers it. I'm really keen for anyone else to chip in there.
No, that was a great response. But yes, Bernadette or Cam, anything to add to that?
Yeah, I think that covered it. I mean, there's a side effect that it reduces presentations to healthcare. But I think probably the primary reason is it's better, or it reduces discomfort and fever for the infant.
Lovely. And just to clarify, is the paracetamol regime just for the under 2s, or would you recommend it?
Yeah, just for the under 2s. But in saying that, if you've got an adolescent who's had a vaccine and they're feeling miserable and they've got a fever and all of those things, it is part of an appropriate process for dealing with those possible post-vaccine responses. Of course, you don't want to assume that every fever after Bexsero vaccine is related to the Bexsero. So while the adolescents don't need the prophylaxis doses, they may need it if they do have a fever response.
Yeah, awesome. Are there any time limits on giving Bexsero if they've had meningitis in the past?
That's a good question, and unfortunately we do come across this in hospital. We give Bexsero and other vaccines at any time a child's recovering from meningitis, within a week, even when they're recovering from meningitis. When we have a meningitis case in hospital, we give them Bexsero. Whānau, the close contacts within that household, also get Bexsero funded, and they also get Menactrol quad food, so they're protected against all serogroup disease. Having index meningitis is a signal of an increased risk amongst that person and their close contacts, so they get protection going forward. So yeah, there isn't a time window. We just do it as soon as they start to recover, which is often within the week if they've been fortunate to be in hospital with antibiotics early.
That's really interesting that you can just give it all at once. That's awesome. That's a really nice cover. Are there any further questions? Just putting it out to the registrants currently here. If there's not, I will just say a massive thank you to Bernadette, Emma and Cam. I really, really appreciate your time tonight. It was incredibly interesting, and of course with the rollout happening, it's a really exciting time for our immunisation schedule. So thank you. And I just want to thank everyone else for joining us tonight. Have a lovely night, everyone. Ka kite.